Good evening, everyone. I'm Liesl from Wildlife Pharmaceuticals, and thank you for joining us for our final webinar for 2022. It's been a roller coaster of a year, but we're very excited to have been able to bring you our series of webinars, and we're looking forward to bringing you some more in 2023. Some house rules before I introduce our speakers. You'll see there is a feed where you can post questions throughout the talk. Please do so. We've got a live Q&A session at the end of the webinar. So whatever questions you post that aren't answered by our speakers during the webinar, we will then go work through those at the end and get those answered. So yeah, please feel free to post questions and comments, and we will try work through all of them as best we can. And then also for our South African veterinarians, the webinar is CVD accredited. So there will be a link posted in the feed that you can click on just to fill in your details and get your certificate. The same applies for international veterinarians. If you'd like a certificate of attendance, please just click on the link and you can fill out your details and we'll send you a certificate. Without further ado, I'm going to introduce our two speakers. So for those of you who have not done so, the platform, the ME platform does work best if you open it in Google Chrome. So if you're having some connection issues and you're opening another web browser, just try open up the platform in Google Chrome. Hopefully you'll have less issues. So we've got two speakers tonight. They are no strangers to our webinars. The first one being our Managing Director, Dr. Kobus Rath. And for those of you who don't know Kobus, he's had quite a long career as a wildlife veterinarian. He started off the first 11 years of his career as the head veterinarian for Kruger National Park, where he developed many of the systems and management plans that are actually still in use today. After leaving the park, he started his own veterinary practice, and he soon realized that there was quite a big need for conservation medicines, not just in South Africa, but globally. And so he started Wildlife Pharmaceuticals in 1997. And today he remains actively involved, not only keeping all of us on our toes at Wildlife Pharmaceuticals, but also in his practice, Wildlife Vets. And we're very lucky to have him speak for us again. I feel like I bully him into these webinars often.
Apologies, everyone. Liesl has load shedding. So in that moment, she went off. So I just want to also introduce Alex, who will also be joining us for this last webinar of the year. So we have two wonderful speakers for tonight. So without any further ado, I'm going to hand it over to them. Enjoy the webinar, everyone, and remember to post your questions in the Q&A.
Well, good evening, everybody, and welcome to the last seminar of 2022. Definitely not the last one that will be presented by Wildlife Pharmaceuticals, but thank you all for attending this, coming to listen to us. I'm sure as I am so happy that the end of the year is approaching, so are all of you. So we thought that tonight we would take a little step back, and we've had so many seminars that so many of you have attended about various different anesthetic combinations, new products, specific species, and somewhere all of this have to get together and be used in a practical session. And that's exactly what we thought we'll talk about in a little bit more of a relaxed atmosphere tonight and give you some 3 cases of some nice anaesthetic challenges that we had in confined or zoo situations, and you're very welcome to ask some questions at the end. So really nice to have you all on board. I hope that you will have a pleasant time with your family, a festive time, and that we will see you all back again next year. So the first case I want to talk about was an elephant. This elephant was in the Dubai Safari Park, and we were presented with a case where the elephant had a growth on the ear that had to be removed, and it was specifically on the right ear, and therefore we needed to have this animal in a left side recumbency. Now, it wasn't a very big elephant, so we could probably argue that we could roll it if we had to, but we wanted to do it in a controlled fashion. We wanted to have it in a lateral recumbency. It could become an extended anesthesia. We understood that. We didn't know exactly what we were going to see when the surgeon starts working. And of course, it could be a painful procedure for the animal. So we had to take all of that into consideration, and therefore we decided to take a 3-way approach. So like always, preparation is 90%, execution is 10%. And the preparation starts long before the procedure. So should we feed this animal the previous evening? Well, it's a single stomach animal. We immobilize them all the time in nature without starving them. So it isn't that critical. And here, stress is a really important factor. So if the animal normally gets fed at night, we didn't foresee any problem why it couldn't have been fed the previous night. We also didn't want it separated and being all alone. They are gregarious animals. They like to be together, and we decided that we will do the separation in the morning. It's important that we started early. Dubai is not a place known for cool days, and we wanted to get the procedure done early in the morning, and we had to bring all the equipment there, especially mattresses in this case, and make sure that everybody had what they needed. Like, for instance, the favorite keeper of the elephant had some treats that the elephant really likes, and you'll see what an important role that plays. You also have to have everything there for the manipulation of the animal. They're not small, they're heavy, and you need ropes and straps. We also have to look after the physiological manipulation of the animal, and therefore we had an oxygen concentrator, we had water to cool the animal down. And what is really important in zoo situations is that you can never say that we'll be done by 9. So the zoo may well open by 9, so it is important that you coordinate with the people so that should the public enter the zoo, that they can, of course, be kept away from that area where you are busy with a procedure. So the first thing we wanted to do was to get this elephant into a standing sedation. And for that, we used a combination of BAM, which is a premixed fixed dose combination of butorphanol, azaparone, and medetomidine. Now, butorphanol, as you know, is a mixed opioid agonist or antagonist agonist. Azaparone is a butrophenone, and we use that in the combination for blood pressure control. And then medetomidine, obviously, the very well-known alpha-2 agonist. So in this case, we used 2 milliliters of the fixed dose. And as the ratio in this fixed dose is 30 butorphanol, 12 azaparone, and 12 medetomidine in milligrams per mol. That would mean that the total dose of butorphanol was 60 milligrams, azaparone 24, and medetomidine 24. Alex went ahead and darted the animal with the Danninger system into the muscle using a 60 millimeter needle, and of course that created a little bit of excitement for the animal. Now he was also isolated, he was alone and in a pen that he was well aware of or well familiar with, and that was where we decided to do it. Waiting for this standing sedation, you have to be patient. It can take up to 20 minutes for the animal to get really sedated. In this case, it was a lot quicker. And you will start to see some symptoms. Okay, you can already see this trunk is lying on the ground. He is still able to pick it up. This was only like 4 minutes into after darting. The animal will have a little bit of an unstable gait, and it will slow down in its movement. It's important that the keeper who has the titbits entice the animal to the middle, somewhere where the animal is in the middle of a wall, so that you have two sides to work on. But it is also very important that everybody remains really quiet. And the reason for that is very obvious. As we all by now know that medetomidine competes with adrenaline, we don't want to get this animal excited, we don't want to stimulate it, and definitely we avoid touching the animal too soon, because that will be a stimulation. So if you look at this animal, then you will see the trunk is lying on the ground. It's only 5 minutes into the procedure. He's still able to move it, but he's now definitely slower in movement.
It's 5 minutes.
5 minutes, there we have it. Sometimes we see that they have a standing where they start to spread their legs a little bit. I'm sure they're feeling unstable, but you can see the keeper enticing him there. He's still able to pick up the trunk and to take some of the tidbits. Once the animal stands in the position, we can now start to work out the desired side that we want to let him fall. This animal is standing. If you look at this, you can see it's actually a video, but he's standing really quiet. Note the trunk on the ground. The animal's not moving anymore, and that's when we move in. Sometimes in some of the standing sedation elephants, we have the ears falling forward, obviously from the muscle relaxation. And just to give you an idea, look at the difference in the size of these two elephants. The left-hand side one was the one we did. That was a 2 milliliter. The right-hand side was one that we did in Estonia. It was 6.5 tons, and that got 5 mils. So the induction in this case, until we were happy that we could move in, took 16 minutes. Right, what do we do now? Now we place the mattresses on the side that we want the animal to fall. We place a control rope around the animal's neck, and we take it out to what will be the top side of the animal. Then very importantly, we place a rope on the leg that's going to be at the bottom, and we pull the leg between the two front legs, the rope between the two front legs. We don't pull it all by now, we just place it there. And then at this point, we are now ready to manipulate. You can see this elephant is looking like it's leaning against us. That's just because we're supporting it. And they tend to sway a lot when they are standing like this. What happens now is we're going into the second phase where we do a controlled lateral recumbency, and we put an IV catheter into the ear vein, and we draw up ketamine at about 1 milligram per kilogram. That's what we start off with. This guy we thought was about 1,200, but we only drew up 1,000 milligrams or 1 gram, which we then administer intravenously as a bolus. So you stop administering when you can feel that the animal is starting to drop, and you coordinate with the manipulating team. Okay, so what the manipulating team is doing is they're keeping tension on the rope so that the fall is controlled, while they're pulling the back leg forward so that the animal comfortably goes down on the left-hand side, and while the people on the side of the elephant pushed it. We ended up at about 0.5 milligram per not per mil per kilogram, and that was enough to get the animal down. Okay, so there Alex is administering the antidote, and we're ready to push the animal. You can now see that it's leaning over to the other side. We pull this leg forward, and we slowly let the animal go down nicely on the mattresses. So it's also important that we keep the trunk extended. As you know, elephants are one of the 4 groups of animals that are obligatory nasal breathers. We're talking about elephants, equids, rhinos, and rabbits. And it's important that we always keep the airway open. And we control the fall with the rope around the neck. Once the animal is down, you can put some ropes on the bottom front legs and hind legs, and then you turn the animal until you get it into the position that you really want it to work. We extend the trunk nicely so that the animal can breathe. I just want to say to you, this is where we've had some challenges in the past, especially if you're working with a really big animal that is extremely heavy. And you have to be very sure that there's no pressure on the top of the trunk where it goes into the skull. We've had it occluded in some animals, and you have to really react to that because it does compromise the animal. So that's one of the things that you have to look out for. All right, what happened with this animal? We supplied oxygen by putting a tube up the trunk. Okay, the temperature of the animal was a little bit elevated in the beginning, 36.8, and it stabilized at 35.6. The heart rate also started at 48, went down to 42 for the entire procedure, and the respiration rate went down to 5 breaths per minute. We weren't concerned. It was moving a lot of air, and it's always important that we don't judge the rate, but also the depth. The pulse oximeter stayed above 91. We used the ear. If you do use the ear, you have to scratch off the superficial keratin layer. In this case, no top-ups were needed, but if you have to give top-ups, we would suggest ketamine at 0.5 milligram per kilogram intravenous. You still have the catheter in at this point. Then we went to the third phase, and we used local anaesthetic. And it was injected, and I don't have to teach any of you where, but all around the tumor that we had to cut out. And then the surgeons from the Dubai Safari Park jumped in. They really did a great job and worked very quickly to remove this tumor completely from the ear of the elephant. At this point, the elephant was really stable. We had no concerns, and we were very comfortable with the procedure, and it could easily have carried on much longer. When you get to the reversal, If you had to top up the animal, I would suggest that you don't reverse within 15 minutes of the last ketamine top up, simply because we are not reversing ketamine and we don't want the residual effect of the ketamine. We remove all the equipment, all the people from the pen. It really has been quiet all along, but we make sure that it stays quiet. And then we place a rope around the neck of the elephant and put some people on it at the back so that we can assist the elephant when it gets up. And we administer the antidote. What did we use? It took 41 minutes from recumbency till we administered the antidote. We reversed the medetomidine at the normal ratio of 5:1 with atipamezole, so the total dose was 120 milligrams. We reversed the butorphanol with naltrexone at 2:1. You're going to ask me why 2:1, because the next animal we didn't use that ratio, and I have no idea why we went to 2:1 in this elephant, because 1:1 would be enough. But you have to be patient because the animal doesn't jump up, especially the intramuscular atipamezole takes some time. And don't try to stimulate the animal to get up. Let him wake up by himself. And when he tries to get up, don't pull on the ropes in the first attempt. You will hear Alex. He will keep on saying, don't pull. And it's a matter of reading the animal. And the important thing is they must lift the head. They have a lot of feet movement and a lot of trunk movement beforehand, but they must lift their head. And then once you have the animal sternal, you completely stop the stimulation, or you stop pulling. You don't do anything further. And that is a really important point.
One thing.
So you'll see some feet movement. The animals sometimes turn. What is really important also is if you are outside and there's an angle, it's really important that the feet are lower than the body of the animal. Otherwise, elephants really struggle to get up. Alex saying, don't pull. See, the elephant's not lifting the head. Starting to get interested.
No? Yes. Almost. No? No?
Just be patient. And that's really important. And now we're getting close. All right, there we go. And the animal is stirring. Now we relax the ropes. At this point, we can relax them. And just leave him. He'll work it out.
Let's go.
There we go. And up he goes. And now we just pull the rope on the one side and let the elephant move away. Once the animal is up, he's not 100% awake. As you can see on this trunk of the animal, you have to monitor for re-narcotization because that can certainly happen at about 3 hours. The atipamezole just has a shorter half-life than the medetomidine, and you can administer additional atipamezole if required, which we had to do with an elephant in Poland. And it was a great team, and thank you to everyone at the Dubai Safari Park. It was a really great procedure. It was beautiful excision of the tumor, and it was a great operation. The second one was a long duration in an anesthesia required in an adult giraffe male at Riga Zoo in Latvia. It was a very big giraffe. They had to do dental work on this, and they had to do hoof trimming, And giraffe, as you know, is already making people nervous just when we start talking about immobilizing them. And I think the most important thing that I can tell you here is that preparation to do a giraffe immobilization in a zoo situation starts a long time before. So about a month before, they started to put some padding into an area where this was going to take place. And the staff have been completely briefed at this point about what's going to happen. So we were looking for a padded room with a soft floor. But the giraffe have to have access to this so that they get familiar with it. Otherwise, if you take the giraffe in there, they are really nervous. So let them walk in and out of it and get really used to it. It's also important that you look at access points for people, because there's normally in these procedures, there are a lot of people there. And if something goes wrong, you need to get those people out pretty quickly. When you get closer to the procedure, of course, you have to brief the staff exactly what to do. You have to have very clear tasks. Who is going to be doing what? That is crucial. There must be no delegation of tasks once the animal is down. Everybody knows exactly what's going on. All the essential equipment is there, and for some animals like giraffe, ET tubes are not an off-the-shelf thing. It takes time to get them. So they have to be ordered, and you must make sure that they are there. Nice blindfolds, long needles for the darts. They have a very thick skin. And with them, because they are ruminants, we do withhold the water and the food. So the first thing that we did here was we used again a combination of BAM, but in this case 3 mils for this giraffe. It was quite big. So it'll be 90 milligrams of butorphanols, 36 of zaparone, and 36 medetomidine. And then only once we saw that we are having an effect from the BAM, we immediately darted the animal with 450 milligrams of ketamine as the total dose. And so here we didn't wait because we wanted the animal to become completely recumbent. It is really important that you don't do the ketamine first for obvious reasons. Okay. They may get super excited, and then we don't get a nice shot in with the BAM. So this was a 2-dart procedure. We used the shoulder of the giraffe, and the ataxic phase is really where you get nervous. The first signs were in about 4 minutes. Look at the gait. Okay, sometimes we find the neck going down. Obviously, from the medetomidine, they battle to keep it up. Everybody is extremely quiet. The animal went down in 10 minutes and 15 seconds, completely unassisted. But you can have to go and rope it. Not that we've ever had to with a giraffe, but it is something that I think I would make a decision at some point to assist it just to go down. When you go into the animal, the important thing is remove the darts. There's going to be a lot of people, not all of them are going to be familiar with the dangerous drugs and the protocols around that, so make sure that you go in first and you remove those darts. And then we put on the blindfold, we put in earplugs, and now we stop the stimulation from the animal. Or not stop it, but at least reduce it. And then we can use straps on the bottom feet and around the neck, as you can see there. And we actually turn the animal and try to place it so much in the center of the enclosure as possible. And the reason for that is not because we want to work there, but it is more important when it gets to the wake-up phase. And we also use a headboard to lift the neck of the giraffe. And here you can see Alex holding it up and the guy's coming in with the neck board. Intubation of the giraffe is done by hand, so it's blindly. We don't use a laryngoscope. You go in with your hand. I always ask Alex to do that because giraffe bite, and it should be his problem. We then give oxygen supplementation via the ET tube. We put an IV line into the ear vein. There are beautiful ear arteries on the outside of the ear of the giraffe that you can either use for blood gases or for invasive blood pressure measurement. But I think what's really important is that we massage the neck right throughout the procedure. And that is a very important thing to do. So here we have the team on it, and you can see the drip there, and we only have a 1 liter bag on it. So is 1 liter actually doing any difference? No. We're not giving IV fluids. We're simply keeping an intravenous access open for emergencies. The heart rate in this giraffe was pretty stable, between 32 and 36 beats per minute. The temperature stayed at 37.1. It's probably because Latvia can be bloody cold in November and absolutely miserable weather, but that's another story for another day. The mean arterial pressure in giraffe are always high. And in this case, it was invasive. It was between about 180 millimeters mercury, and we were quite comfortable with that from previous studies that we've done. You will also notice that even though this animal is immobilized with alpha 2 and is very relaxed, that we don't allow people around the feet because they may still kick. They may get excited and they may still kick. And a giraffe of this size will kick and certainly injure a person. So to look at after the safety of your staff, keep them away from the feet. But of course, we have to do the procedure. And if you are going to work on the feet, we put a strap around the feet. We have people pulling on it, holding it back. So should the giraffe kick, it can be controlled. And we have one person close by in the suicide triangle, and he's holding the feet so that the people can do the work on the hooves. The Riga Zoo brought in a dentist. She's an equine dentist. She had really had fantastic equipment, and she had quite a long procedure to do on the animal, and I must say it went really well. So let's just look at this. Here we have people massaging the neck all the time. We have the blindfold that covers the eyes completely. We have earplugs in the animal. We have intubated it. We have the oxygen line going in. We have an IV line in the ear. And now the dentist is free to do some work. You can see the breathing of the animal. It's pretty fast, pretty regular. We were not too concerned about that. The animal was really relaxed and very stable in all the parameters right through the procedure. It's always strange if you're the anaesthetist, how long it seems for other people it takes to do the work, like the surgery or the dental work. But when you have an animal this stable, it's not a problem. Notice the massaging of the neck, it never stops. Okay, we keep on doing that. Ensure that there's good blood flow through the neck. Right, when everybody is done, it's time to get the giraffe up. Very similar to the elephant. We put a strap around the animal. The tube is still inside the animal. We wait until the animal's a lot more awake before we pull it out. We take the blindfold off, make sure it's loose, everything is ready. Then we can give the antidote. Again, atipamezole we give intramuscular, 5 times the medetomidine dose. so that would be 180. We give naltrexone at 1:1, and we remove the headboard at this point and put the neck down. But we don't stop massaging it, okay? We don't stop massaging it. So we still have the strap around to help us getting it up. And then when the animal starts with the effort, we will lift the head and pull the animal into a sternal recumbency. And that's when you leave. So we will physically lift the head, get the animal sternal, and then we leave it alone. And one of the interesting things that we've seen in field situations is that the animals need to adapt their eyes to the light. It seems that giraffe, that if you have this blindfold on and you take it off suddenly, they are really blinded by the new light or the bright light, and they have difficulty in seeing. So this is really nice. And what happened here was the animal started to show signs in 2 minutes. We pulled it up sternal in 6 minutes, and then we just left it. And the longer that animal lies sternally, the better, because there's no chance of regurgitation, which can be a huge problem in giraffe. And it has all the time to adapt. It has time for the antidote to work in. It is dead quiet. We don't stimulate the animal at all. And the animal laid there for 6 minutes and then got up at 12 minutes in the first attempt and started walking around. You will also notice two things from the trials that we did with the BAM in giraffe. We had these two parameters that we measured: time to tongue out and time to tongue in. So one of the first signs that we'll see is that the giraffes, the tongue will come out of the mouth with the BAM, and it's probably the effect of the metatomidine, the muscle relaxation. And then when the giraffe get up, it isn't uncommon to still have the tongue out. And after a while, it will pull it in. What we do see in giraffe is re-narcotization. Not severely, but we do see it. In this case, it was about 3.5 hours. Bad enough for the zoo staff to call us back to it. We didn't administer anything. We weren't concerned the level of ataxia wasn't that bad, but it is something that you have to consider. Again, a great team at the Riga Zoo. All the keepers were so good with the preparations. Everything we asked for were done by the day we got there. And everybody was just simply so cooperative. It was a wonderful procedure, and thanks to them, and well done. Well, that's my side. Alex is going to continue with another case, and then we're going to break into some questions. See you later.
Hello, everyone. It's once again, it's great to finish the webinar year with such a great topic, with such a great co-lectures. Thank you, Wildlife Pharmaceuticals, for organizing that, and thank you, Kobus, for the review of the elephant and giraffe. It was really nice, and I was happy to listen to that and see and remember the case once again. So my case will be slightly different. I will rather discuss the case about the disease when we actually rather need to protect our animals from that than screen them once they already feel bad. So I will speak about one chimpanzee that went for cardiac screening, but I think it was a little bit too late for this particular animal. So first of all, for those of you who didn't participate in our previous webinar, where Dr. Laholaket already gave a really good introduction to cardiac diseases and cardiac problems of great apes, you always can check this webinar afterwards. It was recorded. So we all know now that great apes, particularly chimpanzees, they have quite high incidence of heart diseases, and especially the disease that we call idiopathic cardiomyopathy, that we can see quite often in captive population of chimps. So they needed to be screened time to time to prevent the development of disease and actually extend the life span of the animal. So we know that the full prevalence, the total prevalence of cardiac diseases in chimpanzees can be up to 67%. That's extremely high, and it's mostly connected to fibrotic cardiomyopathy, mostly males, but we know that actually it's the heart disease generally is one of the most important cause of death in chimpanzees. And here, once again, I would like to refer you to the paper published in 2009 in the spontaneous heart disease in adult chimpanzee. If you will would like to get the good overview of prevalence of cardiac diseases in these animals. So the case that I would like to discuss with you is the adult male chimpanzee. So he was 32 years old, and the main presentation of the case was the progressive weight loss. He had a dry cough, and actually in the beginning he was expected just to have a bronchitis, progressive bronchitis. So in the same time, because it was the internal exhibition, we could see that the animal kind of tired all the time. So we can see the intolerance of exercises. He didn't want to go to shell. He didn't want to move a lot. Keepers described few moments when he had sneezing, so some fluids, some discharge coming from the nose, and there were a few couple of times of vomiting. So because he was expected with the bronchitis in the beginning, he got the antibacterial treatment. Because of vomiting, he got the stomach protection, but there were no results. So just to remind you that the anesthesia of chimpanzees is not very simple because of many factors. They are big, they are strong, they live in the groups, so that's always a challenge to immobilize the chimpanzee as a group member. And of course, like they are quite might be quite aggressive. So with these large teeth, they're really strong jaws, and they are fast. They are really fast. So additionally to that, they are really intelligent animals, and if you immobilize the animal in the group, you need to think about the hierarchy. So either you immobilize just the normal member of group or the alpha male. They are endangered species that under attention of public, so it's all the time challenge to communicate the situation when you need to do the screening or to tell to people that the animal is severely sick. And of course, in this case, we had the medical condition, the health condition that wasn't perfect for this particular animal. Once you work on the animals like chimpanzee or gorilla or any dangerous animals, you need to acknowledge the potential risk for human injuries, because these animals, they can wake up suddenly, and it's important for you to keep the animal in the stage 3 of anesthesia, so in the general anesthesia, not just the light sedation, and definitely check the anesthetic depth during the procedure. So usually what we do, we have one person that checks the digital reflexes of the animals. So do they try to grab you or not? I would also like to remind you that we have common diseases with chimpanzees, so including the tuberculosis, coronavirus. So you need to protect yourself. and you need to protect the animal. So wear face mask and gloves all the time. In case of any emergency, you need to have the protocol what you're going to do if the animal suddenly wake up, and in case of any injuries of people, it's really good to have escape route and the protocol for bite wounds. So if describe shortly the difference or some important things from anatomy, so they're really close to human. The thing that is different, they have really short trachea. So we all the time intubate them. I will go through intubation just a bit later, but I will mention that now that you need to make sure, you need to measure your ET tubes, because what can happen that you can accidentally intubate just one bronchus, primary bronchus, and then you will have the one lung ventilation that will definitely affect your anesthesia. So why we say that the anesthesia of great apes and chimpanzees is not simple, it's not easy, because they have few underlying diseases that can affect mortality during the procedure. So including cardiomyopathy that I already mentioned, arteriosclerosis, they prone to hypertension, the same as a human, and they could get lung edema during the procedure. Additionally to that, they prone to laryngospasm. So that's why, that's again and again, it's a cause why we intubate these animals. And they never have an empty stomach. So they prone to regurgitation, actually, or reflux. Both of them are important, and it can end up with aspiration pneumonia that you don't like to get, you don't like to treat that. So we still can reduce the risks, and we have to prepare the patient as much as possible for risk reduction. So just think about your anesthesia protocol. It's never like, I have just this drug and I am going to use this drug. Please consult, if you have no medicines available, please consult to human doctors around. Maybe they can actually help you with some important drugs. So don't think that if you just have a xylazine in your practice, then you will immobilize the chimpanzee just with the xylazine. So you need to have a good premedication. You need to be prepared definitely for intubation, for monitoring. And if something will go wrong, you need to know what to do in this case. So how I prepare patients, usually fast them around 24 hours before anesthesia. They don't like that. They can show the aggression against you, against the other member of the group. They can vocalize, and just why I mentioned before why great apes have no empty stomach, because once you fast them for long, some individuals, some animals can start eating feces. So as a result of fasting, as a moment how they show you that they're completely upset. So you also all the time you have the risk of regurgitation, and they're prone to that. Try to minimize the stress. Don't walk with your blowpipe or your injector just close to the animal. Don't stress them with lots of people presenting at the zoo at the moment. And what I like to do to reduce the risk of vomiting or regurgitation, I would like to give them metoclopramide just 2 times around 10 hours before the anesthesia and around 2 hours before the anesthesia, just to keep the stomach sphincter a bit more closed. Then I want to sedate them. And you have different option for that, but in this particular case, we use diazepam orally just around 2-3 hours before the induction, and the animal was calmer, but still really reactive when we entered the room. So we gave additional midazolam bit around the hour before the darting, and in 30-40 minutes, the animal was lateral in the, let's kind of sleeping position, but don't let's say overestimate the depth, so they still might react to darting. But the benzodiazepines, they really have a good effect to great apes to premedicate them before darting. So then you need to understand that the principal and important questions for you: should you use medetomidine in these particular patients or not? We know that medetomidine is actually a great drug that will increase the safety for the person working with the animal. But yeah, it's all the time question to be or not to be if you use alpha-2s in the patient with the expected cardiac disease. We all remember that, for example, in dogs that also can have a mitral valve regurgitation or related cardiomyopathy. We definitely would like to avoid all alpha-2s because the heart with this increased pressure sometimes just can be able to pump the blood normally. So there were few studies done on the heart disease and anesthesia of great apes. So at the moment, because medetomidine probably, if would produce any vasoconstriction in great apes, it should be or it is a really short-acting, short effect to vessels. So there's no clear contraindications against alpha-2s, and at the moment, I can't say that you need to avoid that, because on the late stage of anesthesia with medetomidine, probably you would get normal tension or even a slight vasodilation in great apes. So it will be easier for heart to pump. So I personally think, and I strongly believe, that protocol by itself, whether you use medetomidine or not, is not so important as a general management of the patient under anesthesia. So what we use ketamine in the 5 milligrams per kilogram and the low dose of medetomidine. So we expected some cardiac problem, and we decreased medetomidine. So actually, in normal protocol, you can, in a normal animal, you can go quite higher, so up to 0.05 milligrams per kilogram, but not in this case. And I always prefer to use soft darting. So I don't use my injection rifles or guns. I use blowpipe to do that darting freely with the low impact. And just remember, the darting of all great apes can be a bit challenging. So especially if they're in a group, they will scream, they will try to catch and throw the dart, they will throw feces to you, and so on and so on. So it will be like a lots of noise, voice, and stress once you're going to dart them. And the darting size that we prefer is either shoulder, triceps, or femoral muscles. Just remember, they have quite special places that you don't want to dart. You don't want to dart the area around the anus, because it will really severely bleed. And the other position that it's really common for chimpanzees, sitting, as you can see on the picture on the right, and you have the internal surface of the femur. Don't do that, because remember about the femoral artery, and darting the femoral artery can produce a really severe bleeding that might be life-threatening. So this animal was darted, didn't really react to darting because of benzodiazepines, and probably like just a bad medical condition. And the first thing that I do after approaching, usually I place the venous catheter just in a case of emergency. So use a cephalic vein. Sometimes saphenous vein is really good. I use 2 of them. It's not too difficult. And what I usually do, or I would say always do, and me and Kubs really like this approach because we all the time work with people around. I place emergency line with propofol. I need propofol attached to the animal all the time. If in case of sudden recovery, then you just give a bolus of propofol for that. And yeah, the placement of IV catheter is really simple. So sometimes they even have no airs in this area, so the vein is pretty big. I already told you that I really love to intubate them, and I think it's important for them because you can deliver oxygen, you can prevent of regurgitation, aspiration, you can maintain anesthesia with inhalation, and in case of emergency, you can ventilate the animal. And both me and Cobus, we run into a situation when we saved actually life of the animal just because we intubate them in the right time, because sometimes they just stop breathing and you need to have your ambu back just next to you. We do that in dorsal recumbency, although I know that some people prefer to do that in sternal. I just do that as a normal human technique. All humans are intubated in a dorsal recumbency, so I use my curved blade for laryngoscope to leave the tongue and the lower jaw up, and I pass my tubes just into larynx. So these are just 2 short videos of intubation and how you can check the tube. And that's the same video, just you see that curved laryngoscope for that. Before you intubate, I all the time provide the local anesthesia of the vocal folds because they're prone to laryngospasm. I told you in the beginning, and yeah, I use just lidocaine over the larynx, and you actually will be surprised that the trachea is quite narrow, so you can pass just 6 or 7 millimeters tube to that, and don't forget to measure the tube from the teeth to upper inlet to thorax. So don't go deep. The trachea is short, and if you need, just cut the ET tube from the higher part shorter. And now we are going to monitoring. So we maintained this animal on the isoflurane, quite low, 1.5%. And we did the full monitoring of all important vital parameters, including the oscillometric blood pressure, ECG, and so on. So to take the blood pressure, we used just oscillometric cough on the limb, and we know that especially males, they're prone to hypertension, at least in the beginning of anesthesia. So it's important to measure blood pressure. Just remember one thing: if you use just normal human coughs and normal human machines for a routine measurement of blood pressure, it's really affected by arrhythmias, and you can have a wrong reading. So the use of anesthetic monitor is much better in these animals. So that's the placements of a pulse oximeter. Not always easy because they have the pigmented skin, but the tongue works really well. And we do ECG all the time continuously because you can pick up quite a few arrhythmias during the procedure, and sometimes you need to react on them. So that's the beginning of the monitoring of this chimp. You can see that the heart rate is kind of lowish, but the heart is in a nice sinus rhythm. SpO2 Full oxygen supply is 95. That is also okay-ish. A good end-tidal CO2, so animal is not hypoventilated. You remember that hypoventilation and hypercapnia are just the same. And as I told you in the beginning, it was quite hypertensive. So you see that the systolic blood pressure is 170 over the diastolic 72 with the mean 104. So that was quite high pressure for them. But already 45 minutes after we start anesthesia, so we had a completely different situation with this animal. So the systolic went really low to systolic pressure to 82 with the mean of 62, and not so low diastolic. It was 54 millimeters mercury, because the animal wasn't hypovolemic, but from the systolic pressure you see that the cardiac function is really compromised. And because this is a cardiac patient and it's not hypovolemic, so the fluids, just boluses of fluids, were contraindicated, so you can't go high. And we started with dopamine. You remember that dopamine is the interesting drug that is the effect of that is the dose dependent. In the low dose we have just positive inotropic effect to the heart, so the increased inotropy and increased heart rate. If you will go high, you will produce vasoconstriction, and it's not good for this animal, for this heart, because the heart is probably not doing well. So the high dose of dopamine definitely contraindicated. So 55 minutes, so 10 minutes after we start dopamine, we're still low. It's a bit increased, but we still have severe hypotension, and we discontinued isoflurane, and we went to concentrate infusion of ketamine, because ketamine with this sympathomimetic effect can increase the blood pressure slightly. And we started to prepare noradrenaline, because noradrenaline is vasoconstrictor. I told you it's not good for this animal, but we couldn't leave the hypertension not addressed in this case. So just before we started with noradrenaline, we took the changing in our ECG. So we got a ventricle premature contraction. You can see two white ventricle complexes that happened just too early, and usually it's not always needed to be treated, but because the blood pressure was low and we had 2-3 contractions, ventricle contractions on the screen in one moment, so we decided that it's a bit too much, and we started with the lidocaine bolus. It was 2 milligram per kilogram, and we put the animal on the lidocaine CRI. By this time, we got the results from the heart screening. We took both X-ray of chest and the ultrasound, the echo, and on the chest X-ray you see enlargement of the heart, and the lungs are kind of a bit reactive with the slight signs of edema around the heart. And on the echo screen you see that both atria, the right and left, are extremely enlarged, and the walls of the left ventricles are quite dilated as well, and quite thin. So we could see definitely that the animal has the really severe cardiomyopathy and congestive heart failure. We couldn't put the diagnosis of fibrotic cardiomyopathy because it might be done just with the histopathology. So actually, according to the cardiac report, we considered euthanasia, and we recommended euthanasia for this animal because it was so severe that we knew that it this animal probably won't survive. Because it already was in heart failure, and management of heart failure presented the heart failure in aggressive animal chimp is quite difficult. Although in this animal we decided to try to recover, so we used atipamezole for medetomidine reversing. You remember from our previous lectures that you need to use more atipamezole for medetomidine in great apes, so we use 1 to 10 or 10 to 1, so 10 times medetomidine dose. So we led the animal into recovery position with the oxygen on the soft padding, because when they recover, they start climb the walls and they fall down. So soft padding is really important. We need to heat them because they lose temperature quite easily, and we left pulse oximeter on the animal. So after atipamezole, animal started to recover. It took really long, but in this case, I saw, like I said in the beginning, that it will be slightly different from previous ones. And the animal unfortunately died a few days after. And I think that what I would do differently in this case, I would plan anesthesia much earlier, and actually we come back to prevention and preventive medicine. We need to know what's happening with our animals in the zoo, and we need to screen hearts of great apes before they will start getting clinical symptoms. Thank you, and I'm really looking forward for your questions.
Hi, Alex.
Hi, Liesl.
Hi, everyone, and apologies for my dropping out in the beginning. It seems like Murphy's Law is having fun with us in South Africa, where we have power cuts. But we're back online. Hi, Quivers.
Hi, Liesl. Hi, Alex.
Hi, Quivers.
Okay, so thanks, guys. I'm going to jump right in with the questions. And I'm hoping as we go along, we'll get some more questions going in the chat section. Quivers, the first question is from John, and it's regarding your experience with giraffe anesthesia. And he's asking about the pros and cons for different anesthetic protocols. For example, thinking of BAM versus etofenothiafentanyl combinations in giraffe. What are the pros and cons of these combinations?
Sure, that's a whole new seminar, but let's do the elevator summary. I think what one has to understand is that we have all these new drugs and we have so many possibilities that we can now really have scenario specific protocols. So it very much depends on what you are going to do and where the animal is, what are the circumstances. Just to summarize, the BAM definitely the main effect there comes from the medetomidine, and therefore any sort of excitement would be more difficult for the animal to go down, as there's a competition with adrenaline at the receptors. So helicopter darting, that kind of thing, you're going to expect to have much longer downtimes than with the opioids. With the opioids in free-ranging giraffe is still my preference, for the simple reason I can get the animal down and then I can do something with it. And now that we have drugs like butorphanol or diluted diprenorphine, we can look at getting the animal breathing much better. But the real thing is, when the animal is running around ataxic, you actually are not in control of the situation. So in zoos situations, the opposite, because with opioids, you will find that you have a lot of excitement. and it is more or not more. It is a lot less controlled than what it is with combination drugs like BAM or detamidine, butorphanol. So you can have a lot more control because the animal cannot run away. It is already confined. So I think, you have to look at the scenario and then say to yourself, what is the best choice that I'm going to make? What is the size of the animal? Is it manageable? Can it escape? Am I in dangerous terrain? Have I got for preparation? And then make a choice. So at the moment, most of the time outside in the field, we still use opioids because we want to get the animals down quickly. In zoo situations, I like to go with the butorphanol alpha-2 combination because I don't have the problem of excitement and running away.
Can I add something
to that? Yes, go for it, Alex.
I'm completely agree to Kobus. First of all, you need to understand the difference between the field situation when you use opioids, and actually you remember all the time that in the field we overdose the animal to stop running giraffe like that. If you are in the controlled situation, so you either in a zoo or in a boma, so enclosure situation. You need to remember that the main physiological difference between these two will be the respiratory depression. You will get really severe respiratory depression using opioids, and you need to think about this one. If you use butorphanol, medetomidine, butorphanol, detomidine, BAM, and ketamine, you will have a heart rate, and Kobus showed you in the video of this giraffe. I think this giraffe had a heart rate about 40, right? 40 or 50, something like that. So you have the high heart rate.
36, 40.
Yeah, it's 40ish. It's not so deep, but it's kind of okayish. But in the opioid, in the thiofentanyl, atropine, we quite often have the situations that you have the heart rate of 4 and in giraffes, and the heart rate of 4 is not good, let's say, because even if it's a deep breath, still probably the animal will be hyperventilate. So you would see that the induction on opioid will be much better and much faster than butorphanol, medetomidine, and ketamine. But once you will start the monitor your animal, you will see that animal on the opioid will be less stable. And that's what we do in the field. Once we approach the animal, we reverse this animal immediately. That's the first thing that we do. Once we approach, we use diprenorphine. That's the partial antagonist. So to keep some level of sedation, but this animal is quite awake already. So that, I think, will be main difference for you. Like as Kobus said, decide what you're going to do and where, in which situation you're going to work.
And that's great. That kind of leads us into the next question where
Alex, you're gonna make people worry.
In giraffes, I all the time make people worry.
It's not the heart rate.
Heart rate, though.
Yeah, but it's not the heart rate that goes.
Yeah, sorry for that. Yeah.
Okay, Alex, so while we're on the topic of using BAM in wild and captive animals, there's a question about using BAM in wild Asian elephants. And would you use it for something like a standing sedation? And what would be the precautionary measures if you did use it in wild Asian elephants?
Kobus, do you want to address this one? That's another seminar. That's another webinar, actually.
Yeah, but it is the same. It's the same thing again. I know. I mean, we did some Asian elephants in India with standing sedations. And of course, they're a lot more sensitive to medetomidine. But again, it depends on what is the approach to the animal, because the main thing that you have to remember with this is the excitement. You do not want the excitement. If you have excitement in the situation of the Asian elephant, then you are going to have an animal that is going to take a long time to go down. If it is a more controlled situation, or you're shooting the animal from a hide, he doesn't know where it is, then that's a different story. We have used it in Asian elephants. They stand really nice with it, but you will definitely have a problem with the induction. If you, for instance, do it from another elephant, as they often do, then I think you are going to have a problem with that.
I'm totally agree. Like you can do that. You can use BAM, but you will need to follow for this elephant for a while. It won't stop quickly. I think Gobus, you will agree with me that it's an option if you have no access to opioids. I think in the one moment you will immobilize the animal, but it will be in a term of preparation that will be completely different procedure. So just the good thing that Asian elephants, they are more sensitive to alpha 2s. So you will need to have a lower dose and actually I think a bit shorter induction comparatively to African elephants, but it won't be slower than 20 minutes that I would approach elephants in a wild.
And I think one of the things that you have to be really careful of is that because of the antagonism, or we can say it, that we get with the adrenaline when these animals are really excited, one of the mistakes that is enticing to make is then you start to give more of the BAM, and especially the alpha 2s. We also have to remember that the half-life of adrenaline is a hell of a lot shorter than that of medetomidine. Okay, so eventually when the animal goes down and the excitement is going away, and you take the adrenaline off the receptors, then you have a lot of medetomidine on board. And it is just something to remember, because you are sitting in this catch-22 situation. You can't get the animal down. It's staying excited. How do you get it down? Well, I give it more drug, but when you give it more drug, then the adrenaline goes away, and then you sit with a really complicated anesthesia.
Okay, while we're on the topic of standing sedation, one of the questions was, is standing sedation safe with pregnant animals?
Like the question about the standing sedation by itself, just a standing sedation, it shouldn't be dangerous for pregnant animal. The question is what we use to reach the standing sedation. So most probably for a standing, we use alpha 2s. Alpha 2s in different species of animals, all of course, every single drug that crosses the blood-brain barrier also crosses the placenta barrier. So they get into the placenta and they produce two effects on the uterus. And first of all, they produce the contractions of the uterus. And the second thing that they definitely produce is vasoconstriction inside of the uterus and local hypoxia. So I wouldn't say that standing sedation by itself is dangerous for pregnant animal. But once you use alpha 2s, anytime you could have the hypoxia in the uterus, so slowing of the blood flow in the uterus. And we remember that the heart rate of any neonates depends on two things, on the temperature and delivery of oxygen. So actually, the drugs that you use for stunning sedation can be dangerous for pregnant animals, especially in the last fourth of the pregnancy.
Thanks, Alex. Then a question about the giraffe cobus. What size ET tube did you use, Alex?
I can comment that.
Alex, tell me about that
Yeah.
funny one.
Yeah,
You
that's
know.
Yeah, that's
because,
interesting.
because you expect this the 5 meters long or 3 meter long ET tube and like a huge internal diameter, but you will be surprised. If I will go to physiology and anatomy of giraffe, remember that the space between the main bronchi, like when the trachea goes to main bronchi, and the larynx will be about 2 meters. So what is the trachea actually? That's the dead space. So there's no gas exchange inside of the trachea. And to decrease the dead space, the trachea of giraffe is surprisingly narrow. So the diameter of the ET tube that we use is just for a small giraffe 14, just 14 millimeters, and for a larger giraffe is a 16. Can you imagine? Like it's the fall that you use this size of tube. And about the length of ET tube, yeah, well, you need to just pass larynx. So commercially available equine ET tubes that we use is around 14 or 16, and they are just I think 50 centimeters or something like that. Even less, it's 40 centimeters.
Thanks, Alex. Then a question from Tobias regarding the chimp. So he knows he sees long hangovers in males after using diazepam as a pre-med. Have you had a similar experience?
I'm with you. I understand what you're talking about. Like, well, let's talk. Let's start talking about the hangover, but they are a little bit more sedated than comparatively to non-diazepam protocols. But actually, yeah, it's true. It's kind of sedation, but I like that because what I can see that under diazepam they at least recover slowly, and they don't want to climb the walls, they don't want to climb shells, and I'm okay with that. It's interesting that actually on midazolam we don't see this effect, but at the moment, for example, here we don't have midazolam pills that we can feed orally. But yeah, you're right. They're definitely, if you compare non-benzodiazepines protocol with the diazepam, they are slowly. Yeah, I don't think it's a hangover, but diazepam has the synergistic effect with ketamine and medetomidine. So yeah, they definitely affected, but I personally like that. And remember, midazolam in great apes and midazolam in many other species produces amnesia. So I like benzodiazepines, and they're safe. They don't remember me.
But Tobias noticed specifically in males. Have you ever noticed a gender difference?
Males.
The males get worse with hangovers.
Well, males always have the difference and the stronger hangover. Well, I think it's a distribution of the drug. So I didn't see the difference because I used lots of diazepam in females as well, and they're kind of slow. Where I think I saw the main difference between males and females are gorillas, because gorillas are so much bigger than females. Then it's just a different distribution, and you have the accumulation of benzodiazepines in the fat tissue and liver, so they can have redistribute. So I think the size matters here more than sex.
Thanks. And then while we're on chimpanzees, Mohammed said, is there any combination that you can use in chimpanzees that doesn't have medetomidine? So, and then you also noted he'd love to know more about the use of diazepam or butorphanol in chimpanzees.
Well, Zolitil definitely is the option with no medetomidine. Just increase the dose, go a bit higher. Especially like this chimpanzee that we presented today, it would be the other option. And I think if I have a severely cardiac patient today, I might go with just Zolitil with really low dose of medetomidine or no medetomidine there. Diazepam always good before before the darting, but remember that Zolitil has benzodiazepine, zolazepam that is long acting anyway there, and don't give butorphanol to any primate. It will produce the respiratory depression because remember butorphanol in primates works as the mu agonist, not the partial agonist antagonist. So you will get the respiratory depression and you will run into the trouble. So don't use butorphanol in primates.
Thanks. And I keep with the topic of primates. Sorry, Cobus, go for it.
No, I can just say, maybe it's just good that we say that we did try. We did add a protocol where we did the baboons with BAM, and exactly the same thing. There we saw that the butorphanol has a massive effect. We also found it almost impossible to get them under anesthesia unless we add a little bit of ketamine. So there are definitely better protocols that there is no indication at this stage to use butorphanol or the opioids in the primates.
Okay, so now the primate question is, what kinds of vaccinations should be given to the great apes and primates in zoos? A little bit off anesthesia topic.
Well, we had this discussion. I was the first vet in Europe that vaccinated chimps against the coronavirus. And I think chimpanzees in my home zoo in Tallinn in Estonia are at the moment the only one that vaccinated. Although I think in the United States they started and I use just a human vaccine. In the United States they use the new vaccine that was developed especially for zoo animals, and they are really successful. So I think that in this situation now, it's worth of that to vaccinate. I strongly believe to that because we have any accident of bad and really clinically important disease in great apes and chimpanzees at the moment in the world. But just remember what will happen if you have the animal that already, for example, has some lung disease, fibrotic lung disease, and you will get coronavirus on top of that. Like how you're going to treat this animal, how you're going to provide intensive care. So I think that's the only one that I would recommend to consider in your zoo. But generally, yeah, we screen them, but we don't vaccinate against other diseases like influenza. So I think the corona is enough, but consider you need to have your risk assessment. Kobus, any idea?
I fully agree with you. It's like with the great apes, as you started off in your thing. Screening of the animals routinely is is the more important thing than just to have a blanket protocol of vaccinating against everything.
So on the topic, what about rabies in primates and tetanus and yellow fever vaccine?
Okay, that's a good one. If we speak about the zoo situation, you need to have your biosecurity plan and a risk assessment for that. So, do you have, because we don't need to vaccinate animals from every single disease. I don't think that, by heart at least, that I remember any case that would be described recently, at least recently, in rabies or tetanus in the zoo. Of course, if you have the open enclosure and you had the signs or like just a history of clostridiosis in the soil, you might vaccinate at least once in 10 years against tetanus, but I don't remember, I don't know any organization, at least in Europe, that would do that, and I didn't see any paper, any case report on that. And well, I live in a country that is rabies free, and we don't vaccinate definitely animals just against the rabies, because we don't expect any source of rabies going into our enclosure with great apes. So I would say no, you don't need to vaccinate against these two, because the chance that you will get rabies or tetanus is really low. And about the yellow fever, I think it's the actual for Central Africa. I'm not really sure. Like I'm vaccinated against yellow fever because I went to work to Tanzania, but it's the only thing that I know about that. I never heard about any great ape that will be vaccinated against the yellow fever in a zoo.
Neither have I heard of a case. So if anybody on the group, have had a case of yellow fever, that would be very interesting, because I've never heard of a case of yellow fever in a great ape, in any of the apes, in fact. So, and that's why I still believe, it's what Alex says. When you have any situation like this, you have to do a risk assessment, and you have to say what are the chances of this happening. What is the history of the area? What is the frequency that it has been seen? What is the chances of exposure? What are the sources? And work out your risk. And rather than to just at blanket vaccinate animals against every disease, because vaccination is not the only way to manage a disease. And if it is a disease that is that low risk, I don't see an indication for it.
And remember one thing, like if in the zoo, you will need to transport and transfer animals from one zoo to another. You will need to fulfill some veterinary requirements, and they will say you that you need to take a blood test that this animal is free of yellow fever, for example, and you will do your antibody tests after the vaccination, and that will show you that the animal is positive in the antibodies with yellow fever. Is it just from vaccination, or animal was sick, or animal was in contact? You will probably, they will say no. Like we don't want you to send your animal. That's the thing at the moment with the avian influenza in Europe. Like, should we vaccinate our birds in zoo collections or not? I'm not going to philosophy of this question, but we know that if we will do that once, we will never be able to transport these birds out from the zoo to any other countries, because it will be positive in the antibodies.
Thanks. And then just two comments before we move off the topic. One from Cosimo, who noted that in Rome Zoo they are currently vaccinating against tetanus, but it must be risk-based, based on risk assessment. And then Heinz noted that they get a lot of, in Sudan, they have a lot of rabies and they get animals from the wild. So it would probably be good to vaccinate them.
Definitely. If you do your risk assessment, if you do a biosecurity plan, go for it.
Great. And then skipping from primates to elephants. So the first question is how would you control hypertension in elephants during anesthesia?
That's the easy one. It's a
Well,
Zapiron that we use.
that's one of the reasons why we have. Yeah, that's why we have the Zapiron. It's actually quite dramatic, the effect of the Zapiron, especially after opioids. When we initially in Kruger captured small elephants, we ran into a problem. We tried to get them down faster and faster, and therefore we were using higher and higher dosages of opioids. And eventually we ran into this pink foam syndrome, where we started to get foam coming out of the lungs, and we went off like a shock lung syndrome, and we were on a different track until we decided to look at the physiological parameters of these animals. And then we realized that we had mean arterial pressures of around 190, which obviously tells you that the weakest system in the vessels are in the lungs, and it was pushing the fluids into the lungs. We then did some work to look at the effect of the butyrophenones, and especially azapiron, and the vasodilatation effect that they have. And of course, that would bring the blood pressures really quickly under control. And in fact, if you have an elephant under a pure opioid anesthesia and you give it a butyrophenone intravenous, the blood pressure looks like the Niagara Falls. It falls pretty quickly. So we use azapiron in the combination. We had to, that's what Alex did his PhD on, play around with some of the ratios so that we could find that we could get enough reduction in the blood without too much other effect. And all the butyrophenones are very well known for this, and that's what they're used for. So we always promote the addition of butyrophenones to a cocktail that contains opioids. I can just say, just like in medetomidine, where the cardiac effects is one of the first effects that is triggered. You always see the vasoconstriction, the bradycardia coming in. And similarly with the azapiron, long before we get the deep sedation effects, we already see the effect on the vasodilatation, of the vasodilatation.
It's actually interesting when you have the long-term procedure on the elephant, and if you have azapiron on the top of opioid, you can visually see the changes in the blood pressure. So you have the flipped ear, like that covers the eyes, and you have the really dilated vessels of the ear. And once suddenly they go contracted, like they just contract, then you know that, okay, azapiron doesn't work anymore. So you give the initial bolus of azapiron IV and you have the dilatation again.
Yeah, just to add to that, so it is obviously very species specific, but I think it's particularly useful in large animals like elephants. But for those that are interested in the topic, we have got a more recent paper in 2020 where we specifically looked at blesbuck with etofine with and without azapiron, and you can actually quite clearly see the addition of azapiron, what the effect is on the cardiovascular system. And then if anyone's interested in the older paper that Kobus is talking about in the elephants, you're more than welcome to reach out via social media or websites, and I'd be happy to share that with you. And then while we are still on the elephants, there's a question about, do you think adding ketamine to the BAM protocol, so KBAM via DART, will help to reduce induction time in wild animals, in a wild scenario for elephants specifically?
I think what you have to talk about here, first of all, is practicality. So, in different countries, there are different concentrations of ketamine available. At the moment, the highest that we can concentrate ketamine successfully all the time without any crystallization is around 250 milligrams per mol. If you want to add ketamine to the BAM, we're going to be talking about around about 1 milligram per kilogram, because it's not intravenous, it's intramuscular. If you're talking about a 3,000 kilogram animal or a 2,000 kilogram animal, that means 2 grams. So 2 grams at 250, that gives us what, 8 cc's. So therein lies your problem. So very often, like we do, for instance, in Hippo, we would dart them with BAM, and then once we have the animal out on the land and he's sort of under control, then we'll give the ketamine. Second thing you have to understand about ketamine is that, yes, it is very, very synergistic with your opioids and with your alpha-2s, but it also has a short duration. Now, if you give a low dose of ketamine and you already take 20 minutes for your animal to go down, you are not going to have a very significant decrease at a 0.01 or whatever you're going to end up with milligram per kilogram in a dart. So I think the volume of ketamine is the biggest drawback in elephants in a dart.
Answering your question, yes, that will definitely improve the time of induction. But how practical is that for elephant? I would say that you need either to dart twice, and that will on this point produce more excitation and less effect of meditomidine. In some animals I do give ketamine, and together with BAM or together with meditomidine straight in the dart. Can be carnivore, bear, tiger, lion. It makes sense, but because still, like, it's not so high volume there. But in elephant, it's just, I will confirm the same that Kobus just said. It's just unpractical to administer that.
I think what you can do is what we did with the giraffe. Once we saw that we have a good meditomidine effect and the animal is really slowing down, and you have a 2-3 cc dots, then you can top the animal up because he's already partially into the effect, and that will definitely help you to stop the animal. But to put it in the initial dart, I don't think that the ketamine is just unfortunately not able to be concentrated high enough to get it into a small volume.
Yeah, but keeping in mind, because those were also captive giraffes, so they weren't running anywhere. If you wouldn't practically do that same scenario in the wild.
Don't do any BAM on wild giraffes.
No, but
talking elephants now, but yeah. And then on the topic of alpha-2s, Hyde wants to know, what about xylazine? So you didn't mention, neither of you mentioned xylazine at all. Is it considered old-fashioned?
Well, let me discuss that on this way. It's, we need to move, we need to take some direction. And xylazine is the good old drug. I can't say that it's like an old-fashioned, especially if you have nothing else. If you have no meditomidine, you can use xylazine successfully. But there are a few problems with the xylazine. Xylazine produces an arrhythmias, and it produces second-degree AV block Mobitz 1 arrhythmia, and you can see that if you will put the ECG on the patient, you can see that 6 hours after you use that. Of course, like we check ECG on the animals that are cats and dogs or horses, and I think, and the concentration in many countries is the issue when you have just a low concentration. But if you have no meditomidine available or detomidine, well, I have no problem. Like you need to use xylazine for that. I still have actually the powder of xylazine, and I use that for camels, for example. I do sometimes Hellebrunner mixture because a camel is just a huge animal. But yeah, xylazine is the drug that you can use. But then another thing that you need to remember that xylazine in many animals, I think Asian elephant and all ruminants, not African elephants, binds 4 types of alpha 2 receptors. There are alpha 2 A, B, C, and D receptors. And if you need to recover your animal and you need to reverse the animal, then what drug do you use for that? Mostly use atipamezole. And with atipamezole, it's the kind of receptor-specific drug that will reverse only A, B, and C receptors. So you will still run with these D receptors that are in central nervous system that will be occupied by your xylazine. So you will have the still partial sedation. So arrhythmia and vomiting and carnivores, and the third thing is just the partial reversing. I think these are issues why I use meditomidine or detomidine rather than xylazine. But once again, if the best anesthetic is the one that behaves well in your hands.
Thanks, Alex. I think that is most of the questions. Just for all our attendees, you'll see in the chat section that Vetlink has just posted the form for the attendance. So for the South African vets, if you click on that, you'll get your CPD certificate. And for our international vets, if you complete it, you can still get a certificate of attendance. And I think that is about it for questions tonight. If we've missed anything or you think of any questions afterwards, feel free to reach out to us via social media or via our website. And yeah, then we look forward to bringing you some more webinars in 2023. Hopefully, Alex has got the next topic, which should be an interesting one. He'll be talking about marine mammal anesthesia, and we've given him ample time to get lots of case studies and experience under the knee. So we're really looking forward to that. So yeah, keep an eye out on our social media for that upcoming webinar, or if you've registered on the website, you'll get a notification for when we've set the date.
So from my side, I would like to thank you, all of you that participated. Lisa Velkovus, it was a great year to do webinars all together, and I'm really looking forward to continue. I think it's quite cold and snowy in Estonia, and we start to prepare for Christmas. So in the last webinar, I can really wish you a really calm and nice Christmas with your families, and it's always we're getting tomorrow in December, so prepare for a good New Year celebration as well.
Thanks, Alex. I just want to say from my side as well, there's also, and to Isabel in particular, they have gone to a lot of trouble with these webinars. They're very patient with me and Alex, who sometimes give them the recordings minutes before. And that's only after Liesel has been pushing us for the last month. And thanks for your patience as well, Liesel. Thank you to everybody all over the world who attends these. Thanks for interacting with us afterwards. This is what this is all about. And to share knowledge, share information, stop making repeating mistakes, and in the end, it's all for the welfare of the animals that we really care so much about. We're having a wonderful, warm December in South Africa, and as Alex said, same from my side. I wish you have a really pleasant and safe time with your family. Thank you.
Yes, and thank you, Alex and Cobus, for all your patience. I know we can be a lot sometimes trying to get information.
Okay, we lost Liesel.
There, I'm back. My camera has gone on holiday. I have tried to put it on, but it just goes black. There we go. Sorry.
Switch the light on in the room.
I am giving up. I think Murphy is tired. I think my computer is saying we should be done with the webinars for the year. But what I say is thank you very much. And for everyone that's constantly following us and giving up their evenings to sit and listen to us, it's always good fun, and it's great to see the interaction and to hear the questions. We really appreciate it. Okay, well, I think that's it. That's all for now, folks. The social area is open.